Welcome to InnerSight, Health Optimization with Rudy and Shaun.
Okay, Shaun, here we go. Podcast number 29. Welcome to our InnerSight guests. We're moving along, and today we're doing skin.
Yes, a very important one, especially in sunny South Africa. I think, we need to talk about skin and what we can do to prevent certain things happening to ourselves.
So it's a major part of what we do at InnerSight for a few reasons, and we'll touch on them now. But with everything that we do, we always bring in a specialist. And today we've got a specialist doctor of the skin, which is called a dermatologist, Dr. Barbara van Westhuizen. Welcome.
Thank you so much. Thanks for having me.
Barbara, you are a specialist dermatologist in Durbanville, northern suburbs of Cape Town, for someone that's not around this area. And you do pretty much all skin work.
Yes, absolutely. Yeah. So I grew up in the Durbanville area, so I'm born and bred. I love being back in the area. Everything's familiar. I have a very big interest in skin cancer and skin checks. That's a big part of my practice. And then obviously other inflammatory dermatoses, the common things that you would normally associate with a dermatologist, acne, psoriasis, eczema, those types of things. And then a small portion with my practice partner, Dr. Johan, we do a little bit of aesthetics as well.
Okay, great. I think we should maybe just say there's two parts of the skin story. So skin has become a big thing in longevity for two reasons. Number one, you don't want to die early, but also you want to have your skin as beautiful, as good as possible for as long as possible. So I think we're going to touch on both, but maybe we should start with what we screen. Part of our screening in both men and women.
Yes, I think dermatology is such a broad field, and we need to narrow it down a little bit today. I think, shall we start with just why do we need skin? What is skin all about?
Yeah, so I think that's a very good question. The skin is our biggest organ in our body. And basically what it does, it keeps the outside out and it keeps the inside in. So it prevents us from losing a lot of moisture, and it keeps outside pathogens or germs out of the body, and it keeps our organs and our muscles and our fat layers protected inside, and it has very specific physiological functions, and obviously it protects us from the outside elements. So definitely, in my opinion, one of the most important organs.
So in our InnerSight program, we focus mainly on basically only on screening for skin cancer. We don't spend that much time on the other factors of skincare as such, but our focus is on longevity, and that's one of the things that we do is see who we need to screen for skin cancer. And I think we can starting with the skin cancers, and then we can take it from there. So the way we do it in our practice at the moment is questionnaire-based. So we ask a couple of questions on the online questionnaire that they fill in to see if there's an increased risk, and then those patients we then advise that they might need to see you.
Yeah, fair enough. So I usually advise my patients when they ask, when should they have a skin screening? So I think every single person should have at least a yearly screening, whether that is with your GP as your first point of contact. You should be undressing in front of your GP that you trust so that they can have a full skin check of your entire skin surface. And that includes palms of the hands, soles of the feet, that includes your scalp, your whole face, everywhere. If there is anything that is picked up, then obviously that can be referred to a dermatologist. And a lot of people prefer to just straightforward from the beginning go to a dermatologist because often in your GP consultation there's not that much time for you to do a full skin check. It takes a little bit of time, and you have to be really thorough with it. So I would kind of divide it into two age groups. I usually say to people, wait until your child goes through puberty. That's usually a time where your child will need a skin check for their facial skin. Maybe they're getting hormonal acne. A lot of their nevi or early moles will be already visible on the skin. They can still grow and change. Before that age, if you have a child that has one specific very dark mole that you notice is maybe growing or that you're very worried about, that can be checked. But then after puberty, I would say a yearly check. If it's low risk, I will often tell some of my patients every 2 years is fine if you really have very few moles, but most people will need a yearly or every second year check. And then obviously, then we go differently in terms of separate from age, your higher risk patients. And I think then once I have a relationship with a patient, then that patient has had something, either precancerous or cancerous lesions, that definitely changes your follow-up. So patients with precancerous lesions that I'm following up, I will want to see every 6 months. The moment you've had a primary skin cancer for the first time, your follow-up changes to every 3 to 4 months, at least for the first 1 to 2 years. Thereafter, if nothing new is diagnosed on histology, I will then slowly make your follow-ups longer and longer until maybe we're doing yearly again, as long as there's been nothing new in that year. So definitely structured to different patients and different risk profiles.
Yeah, that's actually very important because I mean, we screen both men and women, and in both those sexes, in the top 5, skin is present. And we ask them to then go and see their dermatologist, and it's actually quite interesting. You've got the 2 groups. You've got people that screen, yes, and the others now I've never done it, and just taking myself as a example is I suddenly had a non-skin exposed melanoma, which was picked up very early, and if I didn't screen, that could have been quite a bad situation.
Absolutely, yeah.
And maybe we should talk about the difference, because I mean, for the layman out there are maybe 3 in my mind, but maybe you have more lesions that we really have to worry about that are cancerous, and which ones are the ones that we really worry about, and which ones are not that bad.
Absolutely. Now we're getting to the good stuff. So if we classify skin cancer, we usually divide it up into non-melanoma skin cancer and melanoma skin cancer. So melanoma skin cancer, most people will know about. You're looking for a dark mole that's changing, or any new type of dark spot that's come out on the body. Anything with, if we talk about the ABCDs, you're talking about an asymmetrical lesion, something with an irregular border, anything larger than 6 millimeters or the size of your pinky nail, anything with different colors, anything that's rapidly enlarging, anything that's bleeding or becoming symptomatic. Although a lot of melanomas are asymptomatic. If it's on your back, you might not even know that it's there. So those are melanoma skin cancers. There is a group of non-pigmented melanomas that you call amelanotic melanomas, and those are quickly arising pinkish or skin-colored bumps or vascular types of lesions. So there are anomalies on this list. And then also under melanomas fall acral melanoma. So those are melanomas that you get on the palms or the soles, as well as on the nails. And those are usually pigmented, and they often present quite late because they're not in sun-exposed areas and people don't really know to look for them there. But if we're talking about melanoma as a group, that is our most aggressive type of skin cancer. That's the type that usually metastasizes or spreads very quickly. If we look at something that is picked up early, we want to pick it up at the time when it's less than 0.8 of a millimeter.
Wow.
So less than a millimeter thick. We're talking about a small lesion, 2 or 3 millimeters in size. So that could be something that looks like a freckle on your skin. And that's why you need skin check for that type of specific pigmented lesions, because screening picks up early lesions. And now within the last few decades, we've seen dermoscopy come into our field of dermatology, where we look with properly designed handpieces that have very highly specialized lenses, as well as using polarized and non-polarized light, so that we can actually see into the upper layers of the epidermis. And we're looking for specific patterns. So as a dermatologist, we've had 4 years of training of looking at these lesions day in and day out, and we know what to look for in terms of picking up early changes in these moles. Interestingly, for melanoma, only about 20% of melanomas come from pre-existing moles. So moles that become dysplastic, that change, and we can say how much of those lesions will eventually become melanoma. We don't have an exact number, but we know there is a higher risk. There's lots of publications on that. So we definitely look for those things and we biopsy them. And then 80%, actually come from new. Right? So de novo melanomas.
It's something that you didn't see last year on your screen, and suddenly there's this new lesion.
So the cutoff, as a rule, we use 35. So under the age of 35, you're allowed to get new moles. They're allowed to change a little bit. Above 35, I know it's a cutoff, but that's what we use. And you're not allowed to get any new or dark spots on the body. If you find anything new, it needs to be checked. That is a skin check, And then we move on to non-melanoma skin cancer. The 2 groups in there is squamous cell cancer and basal cell cancer. And those are very common on our lighter skinned individuals. It is definitely also from chronic sun exposure. Squamous cell cancers, that falls under a classic type of cancer. So you have a precursor lesion, an in situ lesion, meaning it fills the epidermis, and then you get invasive SCC. I usually tell my patients, if you can wish for a type of skin cancer, then you rather take SCC or BCC, and definitely not melanoma. So squamous cell cancers, they can metastasize and they can infiltrate, meaning they grow down into the deeper tissues. But if you catch them early, again, because they have those precursor lesions, if you catch them early, you cut them out and they're gone. So what you're looking for there is a reddish or pinkish kind of thing that even starts like a pimple or like an eczematous patch on the face, often more in men than in women because they've had more sun on the scalp and the ears. But typically forehead, scalp, the bald scalp, ears, and neck and chest. Even on the hands and the forearms, and we call them these gritty papules. So when you touch them, they're a little bit rough on the surface. It's something typical that you pick off the scale and it comes back. So every time it will be back. The patient will say, "Doctor, I scratch off the scab," and it will come back. And now when that lesion goes a little bit deeper, we're getting to that in situ phase. Often patients will say, well, now it's actually becoming a little bit tender or itchy. And that just gives us the idea that it's gone through the epidermis. We're reaching the tip of the nerves that come through the dermis. And that's usually, then I'll say to the patient, well, actually, this one we need to biopsy. Most of those early lesions you can treat with freezing, so cryotherapy, and you follow that patient up regularly. And that's your typical type of patient that you'll see 2 or 3 times a year, and just make sure you stay on top of things. Then with your basal cell cancer, that is typically a little shiny papule, again pinkish or skin colored. It will just start on its own, and it doesn't have any precursor lesion. So once it's there, it's there. It's luckily slow growing, and it's usually not invasive. It is just quite destructive. So if you leave it, it often likes areas like the nose, the ears, on the temples, next to the eyes. So you can imagine if you leave it for long enough, it will eventually grow down into the deeper tissues, and it will invade into the cartilage or down into bone, and it's destructive. So you end up having to cut out a lot. So again, for those, you want to pick them up early, you want to cut them out completely, and then you have a really good prognosis for those types of patients.
Okay.
Yeah.
So obviously you see much more of the squamous cell than the basal cell. But the melanoma is the one that's the more aggressive one that you don't want to miss.
Yeah, and luckily now, as I say, with skin screening, with mole mapping, we pick up a lot of in situ melanomas. But unfortunately, a lot of our older patients, they're in denial a little bit. Different things happen. Sometimes they'll have a spouse that was ill. They've gone through that cancer diagnosis recently, and they almost don't have the energy or the heart to go through there. So this week I had 2 patients who came to me, and one patient said, well, my wife had gone through breast cancer for the past 5 years. I knew that this thing on my back, very large dark lesion, was getting bigger, and I actually just could not deal with it. So I said, tomorrow, next week. Similar story for a young man also. His wife had also gone through illness, passed away early this year, and now he pitched up with quite a big lesion on the upper arm. So you still do get a higher grade melanomas presenting to your practice, and you often find there's a little bit of a story, and patient has been in denial for a while.
And when you say now there's a story behind all of this, it's quite interesting, because if you think about mole mapping, so mole mapping was quite new a few years ago, but now we in the age of AI, and a skin lesion is something you can recognize. So that might be something that's going to change a little bit in your field, that you have be able to take a picture of the same thing as it goes along, and also compare it to the 2 million that's been done, pictures all over the 100%. World. So
100%. And that has become the standard of care. If you're going to a dermatologist and you don't have access to a mole map, might be time to move. And most of us are using some form of dermoscopy with capturing images. And most of us will have access to some form of a mole mapping device. There are handheld devices on the market currently, so it makes it really streamlined. It makes it mobile for you to take with you. And those devices have AI built into them. So firstly, you now have the capacity to take pictures of all the moles on someone's body, and you see that person, whether in 6 to 12 months, you can compare side by side lesions to see if we're talking changes smaller than a millimeter within a single lesion. You have AI built in that will, every single lesion you can run through AI. For one device, it's called Amy, and you can ask Amy what she thinks about the lesion. She will tell you whether it's low, medium, or high risk. And that just works on pattern recognition. And then also for your larger mole maps where you do total body scanning, you're able to then compare at the next visit. It does the full scan, lines all of the moles up, and it can overlay images on top of each other and tell you whether there's been change. And it will also pick up any new lesions that have popped up in that map that weren't there at the previous map. So that absolutely is the standard of care. And I think if you're the type of patient who has a busy, complicated back or a busy mole map, that is absolutely what you need to do for yourself.
Wow.
And obviously the importance is that if we pick it up early,
Exactly.
we can excise it, and then you've got the prognosis is much better.
Exactly. If you pick up a melanoma in situ phase, in other words, again, less than 0.8 of a millimeter and lower, it means that you will have a wide local excision with a plastic surgeon. That means 5 to 10 millimeters wider and deeper excision. Usually you don't need any mapping of your lymph nodes because really, remember, checking lymph nodes also carries a risk. If we go and surgically remove lymph nodes, they do have mortality connected to it, meaning that you will have side effects if those lymph nodes are taken out. So the risk is so low that when you have an early melanoma, you cut it out and you have good follow-up. Easy as that. The moment we go above that, 1 millimeter and above, your prognosis changes significantly and your whole workup looks entirely different than the previous scenario.
It's very similar to the colonoscopies that we talked about. Having that first contact with the dermatologist is so important so that they can get your baseline, and then in future if something changes, then that's your key.
And I think that again, it comes back to the story, not just the picture. There's a story to each person, the risk of where their parents was, and it's a big thing for where we drive from. Is the first question we ask. Mum and dad, what happened there? So I think the story, because we also focus on AI quite a bit in medicine, but the story of a person that actually comes through the door is so important. So and again, like you say, Shaun, is get the first map and then get the specialist to tell you when. Because as you say, some people only need 2 years, but the guy with the melanoma needs every 3 months or every 6 months. Yeah.
Sometimes I have people who sit in front of me and they're two spouses, but they look entirely different. Husband will be a very light-skinned, blue-eyed, blonde individual with Scottish or Irish heritage. So phototypically, he has higher risk. Genetically, he has higher risk. His wife is olive-skinned, comes from Mediterranean family. Her risk is lower. She has maybe 2 or 3 moles on the body that we have to monitor. His complete risk profile looks different. Maybe he played lots of sport when he was younger. He has a high cumulative sun history. He has lots of skin cancer in the family. So 2 completely different patient types. And for him, I will say, well, I'm going to see you every 6 months. And for her, well, I'll see you again in a year or 2.
Yeah.
Let's take it one step back as well. So we screen for high-risk patients, send them to the dermatologist. But in actual fact, everyone should be screened at least once.
Exactly.
And then decide what the follow-up period should be like.
Yes. Then you've had your contact. I've looked at every single inch of your skin. I've told you what is there, what is not there. Maybe there's 1 or 2 things I want to keep an eye on. Or actually, rarely I'll tell you there's actually nothing. Keep doing what you're doing, sun protect well, and this is how we plan ahead.
Well, there's something to think about. Maybe, especially in that first contact when you see someone for the first time, not to say, okay, but you're fine because you're not a high-risk patient.
Yeah.
And actually say, well, still suggest you need that once-off visit with the dermatologist, and then you can stratify your risk afterwards.
Absolutely. One of my very first melanoma patients in my practice was a 30-year-old woman. Clinically, if you looked at her, you would say, well, she's got good skin. She doesn't have a lot of moles. She doesn't clearly have any signs of skin photo damage. And she had an in situ melanoma on her calf. Luckily, she had noticed a new lesion. It was about 3 or 4 millimeters in size. And she came through and it was that typical nice and early diagnosis for her. But if you had risk stratified her, maybe, she would have fallen through the cracks.
If we then move on and say then the person waited too long, prognosis-wise, the picture for skin cancers differ between the different strains of type of cancers.
Yes.
The newer treatment regimes, is it available in South Africa at this point of time? I'm not up to date with that.
So I always say, so that the in situ phase, wonderful place to be. The in-between part is actually a difficult part to be. So you're between a stage 2 and a stage 4. That's type of a limbo, because now you've had your scan, you've had lymph node check, and you're clear, so we're following you up. So you actually don't know completely where you are and what we're dealing with. Your stage 4 type of patient doesn't have a great prognosis, but they can enter into trials. So we have big biologic trials running at centers like Cancer Care. We do have a fair bit of access to those types of biologics, checkpoint inhibitors that are really promising. So they work on the T cells, and patients do well on it, but we are giving end-of-life care, and we're trying to prolong survival for maybe 5 or more years. And that still is a big difference for a patient, because that patient might get to see their child go to university or might get to see their grandchild being born. So, I think that makes a big difference for a patient. So I would say we have limited access still at this stage. These types of treatments are extremely expensive, but there are wonderful trials running. And if you channel your patient into the right center, they could have access if they qualify for it.
Okay.
Just for our listeners out there that might not be medically trained, just do all skin lesions travel via lymph? Or is it you're speaking 1, 2, 3, 4 stages?
Yes.
So is it mostly lymph that
it's mostly lymph, because you go and look at that sentinel, though, that primary draining lymph node for melanoma. Yes, it can. Then from that lymph node, it will travel to other sites and through the blood, obviously. But yes, for melanoma, that's the primary one. If we're looking at non-melanoma, hardly ever for basal cell cancers, maybe less than 0.01% in the literature. And for squamous cell cancers, if they start invading, then they go via either blood or lymph.
Okay.
But melanoma, usually we go and look for that sentinel node. And sometimes the node can be negative, and you might have micrometastases that you couldn't pick up on that node, because obviously, again, we're looking at histology, and we have very high level stains that our pathologists do for us. So a high level of sensitivity, but there is the chance that because the melanoma isn't growing down into the tissue and physically invading, it's throwing off little cells that travel to the lymph nodes.
And then when you said you're in limbo, you're not sure if one of the cells.
There's always a chance. Yeah. So you look at those sentinels. So for the listeners, what gets done is usually when you go for that second excision of that entire lesion, or you go for the wider margins, in the operation, they will inject dye, and that will travel to the draining lymph node basin. So for an arm, that will be under your underarm, your axilla, and then they will look at which 2 or 3 lymph nodes take up that dye first, and we call that the sentinel node. And they will biopsy those, and that will go for staining and for histology to look under the microscope. And then obviously that influences when you have positive nodes, that increases your staging. And then obviously there's further investigations. We do PET scans where they look at hot spots, whether in the lungs or remote spots that light up. Yeah.
Okay, right.
Yeah.
So just go for the screening. Avoid all those things.
You have to screen. And I think that is the base of what our screening, the InnerSight screening, is. The secret to living longer is not to die young. And that is the first part, is make sure you get screened, that you know early, that as we say, there's these red ball that's going to knock you off your pedestal on a Tuesday afternoon. That's the thing that you do not want. And you can actually prevent most of it if you do it properly or prolong it. So
and I think the beauty of it is it's not an invasive examination.
No.
Someone is going to look at you, maybe take photos and pictures, and that's it.
Yeah.
There's no pain involved or anything like that.
No.
Not for stages, for the screening.
For the screening. So we all should do that.
And usually dermatologists are kind people. We make you comfortable, we give you a little blanket to cover you, chat with you, and whilst we're looking at lesions, we'll tell you everything we see. We're very fanatic and dorky about the skin, so we'll tell you which ones are benign. And I think it's very reassuring walking out of there and hearing that actually there's nothing now that we need to be worried about. Or if there's one thing, we're going to take care of it. We're going to do a small biopsy. Our biopsies are very tiny in size usually, and we guide you through every step of the way.
And a good screen is also better for you, because the news is always a better news than waiting too long.
Exactly.
Okay, maybe let's now swing it around. Now we've screened, we've picked up or not, and we're happy. What's new in skincare? How do we look after the skin? Because our saying is we want to be a kick-ass 80-year-old. So how do we get there?
Yeah. Let's look at the most inexpensive way to prolong photo aging is sunscreen and good sun protection. So the basics, staying out of the sun when it's high in the sky, taking your walks early morning and late afternoon, applying sunscreen, adequate amount of a broad spectrum sunscreen, anything from the shelf that you can get that's at least between an SPF 30 and a 50, and has good UVA and UVB cover. There are obviously sunscreens that work harder nowadays for us, and they come at maybe a little bit of a higher price, but it's still always worth it. If you are looking to start doing any type of aesthetic treatment, any type of active serum or cream that you want to incorporate into your routine, your first step is going to be sunscreen. You can pay hundreds and thousands of rands on anti-aging products, but if your primary sun protection is not there, because remember, those actives are going to make you more sun sensitive, and you're wasting money if you're not upping your sun protection game. So that's always going to be the first thing. When you go on a holiday, protective clothing, obviously keeping your children out of the sun, that's going to be the first point, and teaching them about good sun protection measures. Then what is new? I think if you think about going into your 30s and 40s, every single patient can at least be on a retinoid. A retinoid at night, whether that be retinol, tretinoin, the benefit that you will get from a retinoid, it ticks all of the boxes. You're getting anti-acne, you're getting anti-pigmentation, you're getting anti-fine lines and wrinkles. You're inducing collagen synthesis and banking in the dermis. You are smoothing out your skin texture because it increases your cell turnover, and you are regulating your sebum production. So all in all, it ticks all of the boxes.
And that is something you can just buy?
Yes, you can start with something over the counter, a low concentration, and then as you start building up your tolerance, you can go to your GP or dermatologist and say, actually, I think I'm ready for a medical strength retinoid. And then we can tailor to your needs. I'll ask you, well, how sensitive is your skin? Do you struggle with other things? But a bit of monthly breakouts, is there some rosacea? Do you have very sensitive skin? And we can tailor a plan for you to get you on the right product. And it's all about building up tolerance to a retinoid. But definitely everyone, even if you can only tolerate it every second or third night, you can still get the benefit from it without having the sensitivity.
The skin is such a broad. I think we're gonna struggle fitting this in an hour. But quite a lot of our InnerSight people are in their 40s to 50s, so they've now got children in their 12s to 22s and that, or
yes.
in that puberty years. And while you were talking about retinoids, kids, can I take it?
So if we're talking acne, full-blown acne, the earlier the better. So doesn't always mean that everyone has to be on some form of an oral retinoid, but there are definitely teenagers who are going to benefit from it, and you rather want to do that earlier, before that whole inflammatory process has taken place, before they start scarring. It's the best thing that you can do for your child is to take them for a skin consult early on when you see that the acne is kind of getting out of hand more than what you can control with facial products. And then again, if it's mild to moderate acne, we can definitely start with topical products. There's wonderful things on the market, different generations of topical retinoids, and then you upgrade as your patient according to their needs. So some will fall into the category of topicals, some of them will fall into the category of orals. But would I recommend actives for young children? No. If there's no indication for it, a good normal regime of cleansing, moisturizing, and sunscreen is more than enough, even well into your 20s. I know there's a lot going on social media. I do think a lot of our older teens are over-treating and overstimulating their skin, and that's often where a lot of breakouts and sensitivity is coming from. So age-specific routine.
Is it, I want to come back to that point, especially with social media, but that's a question every now and then someone asks the question, because if you open social media, you're going to see, sunscreen is toxic. You get all these chemicals absorbed in your skin. Everyone's supposed to have an opinion on that.
Yeah.
And I suppose it's the pros and cons that you also need to look at if you're in sunny South Africa, weighing up the benefit versus other stuff. But is there specific brands of sunscreen that you would say is better than others, or does it actually make
ingredients?
Ingredients to avoid?
There is so much that I can say on this topic. So firstly, on the topic of, is sunscreen toxic? Does it cause cancer? Is it toxic to our reefs? This is an endless conversation, but if we just get down back to the basics. Number one, there are much worse things that you're putting in your body that you're taking in through your mouth than the sunscreen that you're putting on your body. Most of the ingredients in sunscreens, the particles are too big for our skins to absorb. So most of them are sitting on the surface of the skin. So they are either absorbing the UV rays or reflecting them. And then we're talking about chemical and physical sunscreens. Where we start looking at nano technology, where they make the particles smaller for us to be able to make physical sunscreen, so the zinc and the titanium oxide more cosmetically acceptable, to not have that white matte look. They make them into nanoparticles. So there is studies ongoing to see how much of that gets absorbed into the skin. But then we have to look at dose. So if we're looking at the toxin, it's dose dependent. Anything that we say is toxic to the body, we have to look at, are we getting enough of it? So none of us are applying enough sunscreen for us to reach toxic levels. That's the first part. And the same goes for reef safety. If we're looking at the amount that we are kind of washing off into the water and threats to our coral, it's mostly environmental, actually. That is the studies they've done to pick up the amounts is the same as a drop into a Olympic-sized pool. So again, not enough. None of us are putting enough on again to get it into that. And then we're worrying about hotspots maybe, around the islands where there's a lot of tourism. Again, our carbon footprint is a much bigger problem. The water temperatures that are rising to, the effect on sensitive coral is much bigger. So that's the one side of what I will say is that most likely the amount that you're going to be putting on is not going to be toxic to you or the environment at this stage. Secondly, if we look at sunscreen as a carcinogen, the sun is a much bigger carcinogen, and that we all know. If you've ever applied sunscreen unevenly, you know that it works. The area where you've applied it, your skin is fine. The area where you missed is blood red and burnt. So you know that it works. I don't think I have to convince anyone of that. And then if we look at ingredients lastly, so a great sunscreen, most of our big brands that are available on the market in our main pharmacies or stores will be an SPF of 30 or 50, have good UVA and UVB coverage. We're looking for long UVA because then we're getting kind of close to our visible light spectrum. A lot of newer sunscreens now on the market have done technology and added filters in to give us visible light spectrum coverage, and that is important for pigmentation. So if we're looking at our darker skin types, they're more prone to pigmentation, or people struggling with melasma, we want visible light coverage. And then cosmetic acceptability. So I say to patients, if they ask me what is the best sunscreen, I'll tell them the best sunscreen that you can have is one that you will be willing to wear every single day. So if it's nice and thin on the skin, it doesn't feel sticky or tacky, and it doesn't leave a white cast, which is important for people with darker skins because no one wants to look ashy or grey. So something that you enjoy putting on that you can see you're going to make that part of your routine, then I'm happy with that. Things with nice hyaluronic acid in them, they spread easily. You need only a thin layer, and you are able to reapply maybe a second time. For a woman wearing makeup, that's a very big thing. They come in powder formulations as well, which I think is great for touch-up, maybe not as your primary formulation, but a lot of them are so spreadable that you can easily apply it over makeup during the day.
And something you also get like an oral sunscreen, like some of the products like HelioCare, I think they make a tablet that you can take.
Absolutely. They make a tablet that contains their fern block technology. Where I would place that, again, is not a primary sunscreen. That would not be your primary sun protection. That is an add-on. So where it's wonderful is if you are going to have a binge episode of sun. So you're going on an island holiday for the next week or two. You're going on a skiing holiday for the next week or two.
Mountain biking.
Exactly. You're going camping in the Kalahari. You're going to get a lot of sun and you want that extra layer of protection. Or for your typical patient who has that higher risk already, who has had skin cancers. There are other things on the market, something like nicotinamide or niacinamide, 500 milligrams twice a day is a wonderful thing that we use. It really makes a difference for patients. They come back and ask for it. So it helps them with the inflammation. It helps to decrease the formation of those new precancerous or actinic keratosis lesions. So yes, there are oral things that we can add on, but they're not the primary thing to rely on. They have a place, but it's a specific place.
And then if you flip it around, the other question is D3 or your vitamin D. And you said stay away from the high sun. So if you get morning sun exposure, it's probably okay because we do test vitamin D in our screening, and we find most people are low. So we find them in their high teens or low 20s, which is too low, and we supplement D3. But the books say you need 30 minutes in a mid-morning sun with exposed torso to get enough D3, which no one does.
Yeah, which is surprising. I mean, we live in sub-Saharan Africa.
Yeah.
Our UV index is high enough for it to cause sun damage most of the year, as opposed to someone living in Europe, maybe an elderly patient who spends a lot of their time indoors. Definitely would expect that type of patient to be D3 deficient. But I think maybe the change in lifestyle of a lot of our population post-COVID, unfortunately, remote working, you spend a lot of your time indoors, maybe also having a little bit more of a sedentary lifestyle, so not really being outdoors at those times of day. Definitely, I can understand it. I think there's also a high risk for our darker phototypes again, again for the same reason. They have more melanin, they're being more protected from the sun. So actually, a lot of studies have shown that they also, contrary to popular belief, they're also quite deficient. So definitely testing for it. And as you say, moderate sun exposure. Times of the day, most of our weather apps on our phones nowadays have, if you scroll down, you can go and see what the UV index is. And usually if you're outside before 8 or 9 in the morning, you can have safe sun exposure. Again, same in the late afternoon. I mean, you don't have to go and sit outside with your shirt off, but if you're wearing short sleeve clothes, then most likely you'll get a little bit of sun exposure in a healthy dose. And then again, D3 also when we're treating field cancerization, so patients with lots of those precancerous lesions, vitamin D plays a big role in the treatment of that as well. We're seeing really good results when it's paired with our, those 5-fluorouracil type of treatment. So D3 is very important in the skin, and it's important because, yes, we can orally supplement, but a really big portion of D3 is made in the skin locally. Yeah, so
Absolutely.
It's a production organ.
That is the best D3 is the one you've made yourself.
Yes.
Yeah, but we don't make it anymore. I mean, I haven't
We're
tested,
inside too much.
I haven't tested anyone. I think we had 1 or 2 patients that actually had normal vitamin D levels.
And what did you find? What were they doing? What was their lifestyle?
No,
Nothing
similar to the others. So it's a weird thing. But anyway, most of our clients or patients are low on vitamin D3.
Interesting. Yeah.
We stopped you at retinoids. Is there anything else that's cool to make your skin nice or look nice?
Yes, definitely. Yeah. So retinoid does a lot. Vitamin C is a big thing.
We're big fans of vitamin C.
Absolutely. And then patients will ask, well, can I not take it orally? So vitamin C applied topically on the skin has a much different effect than that which you take orally. So again, orally, limited evidence and limited application for that, but applying it directly onto skin absorbs very well, has a really nice brightening effect, again, really good effect on skin texture, and it's a great antioxidant. So it helps us to fight back that age clock and that UV damage clock. So that's the one thing. And it's built into, you can get it as serum. It's built into a lot of face creams already, especially if you're looking at brightening agents or products that are aimed at pigmentation. So that's the one. Then I would say probably one of the next things would be, then we're moving into the pigmentation sphere. So then we have things like niacinamide and tranexamic acid. There are lots of topicals. But I think then we're moving into complicated territory. That's more for your doctor to work out a tailored plan for you, specific to your concerns. And then maybe lastly, AHA, so alpha hydroxy acids, glycolic acid, lactic acid. They are chemical exfoliants. Again, wonderful for improving your skin texture, helping with patients that already have those early lesions on the skin, and giving you a chemical exfoliation. So instead of scrubbing your skin, you can put on this AHA once or twice a week. It's also great for things like keratosis pilaris that you get on the arms or the legs, those fine, gritty or dry papules. So that's a very nice thing also. It will also be built into a lot of skincare products. And you want it in a low concentration, so 5 to 10%, where you get that nice effect without having irritation on the skin.
And you can buy that in Dis-Chem or one of the big pharmacies.
There are a lot of local brands as well that are very cost effective. You'll get it in the clicks, that you can buy it from the shelf. You can buy it as a standalone serum or as part of a combined product.
Okay.
And then Something like collagen supplementation.
Yeah.
That's also a question we often get.
Yes. People always ask me, my patients ask me about that. I would say for now, my opinion is I'm not taking oral collagen supplements. I don't think we have enough concrete evidence. We don't have enough data to support the way, from a medical point of view, if you ingest collagen, now whichever source it's coming from, your body, your stomach your enzymes have to break down the collagen into amino acids for it to be able to cross the blood barrier and to be absorbed. Your skin can't miraculously say, I'm going to take these amino acids and build it back into collagen 1 and 3 for me to build up the scaffolding of my skin again. There are much better ways to induce collagen: retinoids, microneedling, laser devices, all of those things where I think you're getting much better bang for your buck. And we have concrete evidence for that versus collagen that we are breaking down and then having to put back together. And if you look at a lot of the collagen, there are some of them that we can take in at room temperature, but a lot of them you have to put in warm substances. You're already hydrolyzing a protein. So then I always say to my patients, if you have a diet that's a little bit deficient in protein and this is your choice of protein, then by all means, but you are paying for expensive protein.
Yeah.
That's what you're doing.
I agree with that. And my view on that is always go back to the pyramid. Have you built the building blocks? And like you said, vitamin C, you need vitamin C for that last step, proline to hydroxyproline, and you need iron if you don't have an iron level. So do all the other things. And like you say, if you don't eat choppies or steak,
exactly.
then maybe. But if that,
it's
like you say,
an expensive supplement.
Yeah,
gosh.
yeah.
I think we need more evidence on that. Yeah.
Good.
Yeah.
And I mean, there's so many pills that I've now had. Is there anything else that you want to touch on? I mean, for me, I think the main thing is I think you're going to have a rush of people wanting to come to your practice.
They are more than welcome.
So I think the other part is, let's say we've got someone in Durban or Joburg, or how do you find, have you got a society or somewhere where people can go, okay, I'm in Bloemfontein, or how do you find a dermatologist that's up to date, close to you?
Yeah.
That's probably.
So I would say there are a few ways. Number one is Google. Google Maps, if you Google dermatologist near me, you'll get 3, 4, 5 options and you can take your pick and contact them. Obviously, word of mouth is great. So hear from your friends and family who they've gone to, where they had good experiences. A lot of my patients, when they come to me, they've already been on WhatsApp and Facebook groups. They've already researched. So just go and read up. Most of us will have an online presence, a website, or some listing on LinkedIn or on some medical websites. And people love doing that because I think in this day and age where social media is so at the forefront, you want to go and see what your doctor looks like, and you want to see whether you're going to have personal rapport with them. Do I trust this person? What is this person saying online? Does it sound legitimate to me or not? Do I think this is a good fit? I think that's very important for patients. And then there is there is a website called Dr. Derma that offers online consults. A lot of the South African dermatologists have signed up with this company so that if you're remote, say you're sitting in the northern part of the Northern Cape and you need a dermatologist consult, you can go via Dr. Derma and book an online slot. A lot of us will, if you contact us, will offer the option of doing online consultations. I do the same. I have a few very remotely located patients, and then we either set up a Zoom call or a WhatsApp video call and we do a consultation. You would typically send me some pictures before the time, and then we chat through your concerns and your whole skincare regime. And I think it's a nice last point to have, is that I think dermatology has evolved so much that yes, it's definitely your skin check, but it's skin health as well. Most patients will bring their skin products to me when they're in consult. So the last 5 to 10 minutes is spent just chatting through the regime, seeing where we can tweak and improve a little bit. And then lastly, just making sure their sun protection game is very strong.
I think the nice thing is you'll have a nice video to put on your website now.
Absolutely. There's more than enough. They can go, Instagram and TikTok, it's amazing how those two platforms differ. Instagram, I think, is a little bit more polished. People like more well-prepared content, where TikTok is just very informal. I literally can sit at the end of the day and make a quick 2-minute video. In Afrikaans nogal, baie lekker. It's a niche. Mense wil dit in hulle eie taal hoor. And people find you there. People will come and say, well, actually last week I've never consumed this type of content before, but I saw your video on skin checks and skin cancer, and the pin said you were in Durbanville because you can click your location when I post the video. And what an amazing tool. People can find you without actually meaning to. So sometimes it's just meant to be. You were due for your skin check.
We're going to try and let them find you. So we'll link your details into our show notes. So that'll be nice. And thank you so much. That was you were made for the studio. You did very, very well, and it was nice to have you here.
What a lovely thing.
Thank you for your time.
Thank you so much.
Thanks
for having me. Yeah, thanks.
Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.